first be trying to find the mechanism of injury. That is either a valgus force, which is going to be a force coming from the outside acting on the knee, or a varus force, which is going to be a force coming from the inside of the knee. I'm going to be checking for the location of the pain. I'm going to be checking for the type of pain, whether it's sharp, dull, aching, or burning. I'm going to be checking if the pain radiates anywhere else, establishing neurological pain patterns. I'm going to be checking if there's a certain time of day that it aggravates him worse, whether it be in the morning, in the evening, or after activity. I'm going to be checking for any diseases or pathologies that could be associated with the knee, whether it be arthritis or some kind of surgery. I'm going to be checking for any sounds or sensations that might have happened at the time of injury. I'm going to be checking if there have been any changes to his movement patterns or to any kind of sports training, such as like cutting drills or like chop blocking drills with football. I'm going to then check and see if any movements are affected or any certain ADLs, such as walking up or down the stairs or walking on uneven surfaces. And then lastly, I'm going to check to see if he or anybody else has done anything to treat this knee.
Okay, so for the observation portion of this assessment, we're going to be looking at knee alignment, and that includes genu valgum, which is where your knees are kind of turned in towards each other, genu varum, which is where you're kind of bow-legged, or genu recurvatum, which is where the knees are hyperextended backwards. I'm also looking at the patellar alignment, and that patella alta, which is where the patella is sitting higher than usual, or patella baja, which is where the patella sits lower. I'm also looking at whether the patella is squinty-eyed or frog-eyed, which is where the patella either is lateral, and that's frog-eyed, or if the patella is more medial, and that would be the squinty-eyed. I'm also looking for obvious deformity, the bony alignments, and swelling. For swelling, I would do a ballotable patella test. I'm also looking at scarring and soft tissue structures, whether there's atrophy, if he's had any past surgeries or anything like that. I'm also going to watch him do a squat and just observe that, see if his technique is proper. Quadriceps muscles, we have the rectus femoris, which is coming off of the ASIS and running down into the quadriceps tendon. Also running into the quadriceps tendon is the vastus medialis, which is running on the anteromedial side of the thigh, and then the vastus lateralis running on the anterolateral side of the thigh. These, and the vastus intermedialis, which is underneath, we can't palpate that, but it's also running into the quadriceps tendon, which attaches onto the patella. And the patella is here. It's a sesamoid bone. And then you have the patellar tendon or patellar ligament that comes off of the patella and onto the tibial tuberosity, which is here.
The MCL.
Okay, and the MCL is on the medial side of the knee, and it's going from the femoral epicondyle to the tibial plateau.
Under it, it's going to break off of that tibial nerve, first coming around the lateral aspect and then going medial down the foot.
Okay, from the head of the fibula.
The fibular head is going to be right here. It's hard to see it, but he's kind of hiding right there.
The IT band.
The IT band is going to be running from the lateral portion of his hip down the lateral aspect of the leg, finding Gerdy's tubercle and inserting there.
Okay, and the hamstrings.
Okay. Can you flip over on the table for me? So I'm going to pull your leg up. Can you push into my hand for me? So the biceps femoris tendon is going to be right here on this lateral side where I'm pinching, and the semitendinosus is right there where you can see. Now a little bit deeper, you can't see it as well as the semimembranosus tendon, which is going to run with the semitendinosus and biceps femoris right back up into the ischial tuberosity. And the LCL, since we're here, is right here from this lateral epicondyle to about the fibular head. And that's where it's going to span. And I would check all those structures bilaterally.
Okay, so we're going to do some manual muscle testing, starting with flexion of the knee. I'm going to have him kind of try to flex the knee, and I'm going to resist it towards the ground. If he can resist this for 5 seconds, that's a grade of 5. If he breaks, my resistance, that's a 4. And if he can only do it against gravity, that would be a 3. So I'm gonna have you resist this motion. 2, 3, 4, 5. Okay, and now you can flip over and come to the end of the table. Kind of scoot forward. Okay. And now I'm doing manual muscle testing of extension. So I'm gonna have you try to extend your knee. So up like this, okay? And then I'm gonna resist downward. 1, 2, 3, 4, 5. Okay, and lastly, I'm gonna have you bring your heel up on your shin, whichever one you want to do, that's fine. Okay. And then make sure your arms are not, yeah, there you go. And I'm going to provide a force that's lateral and down towards the floor. And you try to resist this. This is testing the sartorius. Okay. So just measuring, the stable arm goes up towards the greater trochanter. The axis is at the joint here. And then the movable arm extends toward the lateral malleolus. So extension should be between around 10 degrees, 0 to 10. Okay, and then I'm going to have you bring your knee up into flexion as far as you can. Okay, and this is the same positioning of the goniometer, but normal would be between 130 and 140 degrees of flexion.
I'm going to sit on his foot, finding the tibial plateau, cupping around back, pulling. Positive sign is laxity for an ACL tear, and this is a anterior drawer test. Now in the same kind of setup, I'm going to push posteriorly on him, checking for laxity, which would be a sign of a PCL tear. That's posterior drawer. Now I'm going to get you to turn your foot up for me. With his foot turned out, I'm going to do an anterior drawer, going this way, and now I'm going to put your foot like this way. So you go ahead again, doing another anterior drawer. That is a Slocum's drawer test. With his foot facing this way, I'm checking anterolateral instability, and with the foot turned out like I did the first time, checking anteromedial instability. Now in the same kind of setup, I'm going to push in, and then with his foot out again, I'm also going to push in like posterior drawer. That is a Houston's test. With his foot turned this way, I'm checking for posterolateral instability. And with his foot turned the first way with my thigh, I'm checking for posteromedial instability.
So for a valgus stress test, I'm going to pick your knee up a little bit, your leg up, just extend it out for me. And I'm going to provide a valgus force, and that's going to stress the MCL ligament. So. And then I'm going to bring it into 30 degrees of flexion and internally rotate the hip. Okay, and then for a varus stress test, I'm just going to provide the force medially so that it stresses the LCL. Okay, and externally rotate the hip. And then for the Walkmans, I'm going to prop your thigh up here. And I'm going to find the tibial tuberosity, come around to the underneath side, and I'm going to pull up superiorly while stabilizing at the femur. And that's testing for the ACL. Going to bring the knee up to flexion. I'm going to kind of dorsiflex the foot and stabilize at the femur. I'm going to provide a force downward and kind of turn it back and forth. This is testing the meniscus. So he would feel pain, clicking or something like that if he did have a tear. Okay, and then I'm going to, in the same kind of hand positions, I'm just going to distract it, pulling up and turning. And that is testing for the MCL and LCL and just the joint capsule stability.
Right off the bat, finding that fibular head again. Common peroneal should be running right underneath of it. I'm going to do it to nils like that. Any burning, tingling. Okay. Now within a short second, I'm going to go ahead and take your sock off. I'm going to feel around the posterior aspect of the medial malleolus, pulling anteriorly, finding his posterior tibial pulse. And this tarsal bridge right here, I am going to feel for his dorsal pedal pulse. And I'm going to do a capillary reflex right here, blanching the nail and then seeing if it refills and what timing. Okay, so now for myotones. So if you could bring your foot back up just like that for me, that's L4. Now go ahead and relax. Now pull that great toe, that big toe in the same fashion, that's L5. Okay, now I want you to go ahead and plantar flex and invert like that. Yep, that is S1. Can I get you to lay on your stomach for me, please? All right, and pull this leg back up towards you, and that is S2. Okay, can you come back up to the sitting position, please? Now dermatomes. So close your eyes for me. That's an example of a dull sensation. That is an example of a sharp sensation. I'm going to list these on different parts of your leg, and I want you to tell me which one's which. Okay?
Dull.
Okay.
Sharp.
So that is L4.
Dull. Sharp.
That is L5.
Dull.
Sorry.
Sharp.
That's S1. Back up again.
Dull.
Okay.
Sharp.
Okay. And that is S2. Okay, now reflexes. Find this patellar tendon. Just relax that leg for me. Think about something happy. Get distracted. There's this reflex for L4. L5, I'm finding his posterior tib. I feel him plantar flexing into my foot and inverting. Okay, can you lay on your stomach back on the table with your feet hanging off? S1, I'm checking the Achilles tendon. Let that foot go nice and nice. We've got a very strong reflex there. Okay, and now I'm pulling you back up a little bit into flexion, finding that biceps femoris tendon again. And it's very light, but he's going into knee flexion. And I would check all of those structures bilaterally.